consolidated with them.
So I'm going to heron.kuc.edu.
Has everybody logged in already? Show of hands. Okay. Hopefully. Okay. So follow along. So everybody should be logged in now, or be logging in now.
Real quick, we've got links for training materials. If you have any questions or problems, we've got links on the side. You can go directly to us. Anytime you use Heron for your research, we ask that you cite us, cite both the CTSA grant and ourselves. And then at the bottom, we have information. We have clinics the first and third Wednesday of every month from 12 to 1:30. And you're welcome to join us with questions or just to get an overview of Heron. We'll discuss Heron and redcap. Yeah, Tuesday.
Tuesday.
Thursday.
You said Wednesday.
Oh, Tuesday. So we're going to start by going over the data types. Searching in Heron is pretty straightforward. You drag and drop stuff into the query and execute the search. It's pretty straightforward. What is a little more complex is the data, because there's a lot of it. We've got the data broken down into all of these buckets. You can see there's alerts, which we've pulled in. It's still in draft format. But you can see there's quite a few. We just brought in, do you want to discuss the alerts for us?
And maybe scroll it over a little bit. So, we're setting up, so I come from Vanderbilt before, where we did a lot of work to build EMRs and to study their effectiveness. So for an informatics perspective, it's a critical piece of data to know how the EMR is being used. But also, as we build research methods for KU and for PCORI, we're going to want to know, are these methods to either recruit people or alert people, are they effective or not? So we went ahead and started harvesting that data. So we've got the best practice. Now, what we call it draft, because ideally we should work with other people across the country to think about nationally, how do we want to organize this data? But right now we figure it's better just to bring it in so people could start to look at it than wait for us to think about how to represent it perfectly. But we do have kind of best practice alerts, so those are the kind of the things built at KU for specific needs. So I imagine, whatever the part you're in, you may say, gosh darn it, we put up an alert to people to warn them about something. How often is that firing? So what's powerful here is you could look at when's that alert firing relative to other things you think should be happening, like adjustment in orders. Then for all our pharmacists in the crowd, we've got some basic warnings around the MAR, but we've started bringing in med interaction checking. So you can see here, we haven't mapped these from a terminological standpoint to the drug classes, but you can start to look and see, for common alerts that are firing in the EMR, how often are they happening? And then you could look at that data in conjunction with what type of medications are on the patient's profile. And so we've got the drug, and then we're going to look at, scroll up a little bit. Did we bring in drug allergy already up at the top? We're working on drug allergy. Will be another one we'll look to bring in to have sitting side by side. And then I think drug dose is in the works or in there. Yeah, so that will be other data we'll have, is start bringing in data about dose too high or dose too low warnings people are seeing.
We also have allergy information that's in draft format as well. So if you're using the allergy information, have any feedback for us, we'd love it. But it deals with allergy reactions. We've got cancer registry data.
And just a comment there, yes, question? Well, now, later on, we're going to talk about the med tree. This is saying the alerts a physician or a pharmacist would see that's warning them that this drug interacts with this drug. We're bringing in the fact that somebody somewhere, probably in the pharmacy or on the floor, saw a warning that said, hey, you're giving two drugs where there's an interaction, or as Suman said, we'll be bringing in drug allergy interactions and dose too high or low warnings. And then again, on the allergies, we think this could be interesting data, but it would be great to have somebody from allergy rheumatology want to use it to kind of see how often things are showing up. And that, again, is kind of tagged as in draft because we haven't had a lot of users use it yet. And you can open it back up, but it's kind of got things, if you look at how the EMRs organize stuff, a lot of things on drug ingredient or drug class. So that's where the bulk of that data is sitting.
Okay. And then we've also, let's see, the next folder. Okay, we've got two for cancer cases. One is the identifiers, that's the abridged. It's basically the same information that's in the folder below, only in abridged version. So this is all of the tumor registry information that we received going back to the 1950s, whereas the abridged also goes back, but it's got the more commonly used things. For instance, you know, you may be interested in the AJCC summary from summary 7 as opposed to the 6 because that one is more outdated. So the identifier one is to help you navigate a little easier. But if you're really good with cancer registry data, go into the full cancer case.
Has anybody dealt with the cancer registry data much at all? Show of hands. So if you're used to it, you'll know that like in the full folder that's unabridged, you've got a lot of data. Like in the old days, they used to use an older version of ICD-02, and then they had a different way of staging. So when we talked to people like John Kegley here and other people from the registry, Tim Metcalf, they said, well, if you had to help the average researcher look at kind of more current data, the top one has kind of more an abridged set of folders that we think most people would want to start looking at. But if you are doing research where you might need to go back to the 1980s or 70s and look at information, you may have a need to dive into deep to the full registry. It would include everybody abstracted at KU. So yes, it should include pediatric cases. Sure. So open up Echo. This is another area where we've started bringing in cardiovascular results. Probably some of the main ones are, if you open up like the 2D Doppler at the top, it's bringing in discrete facts from cardiovascular test results. The way they're kind of parked underneath the test, I wouldn't worry about as much, but like if ejection fraction is probably a key thing everybody's interested in. So that will be the discrete results for an ejection fraction from an echo that's then available for you to look at. There's some other data in here that we haven't really looked. While Shravani was bringing this in, and she could comment more, there were opportunities to go ahead and pull in other stuff. So when you look at like device check data on the top one, it's kind of interesting. You've got like the top folder, the abstract device hardware. I think a lot of this is data from implantable, pacemakers and defibrillators, just about what's happened in terms of the placement of that device and when it's reinterrogated. So some interesting data here for cardiovascular people. Probably the echo discrete results may be of broader interest to the full community.
Okay, the demographics folder, it's got your basic demographics. It's got age. We've got whether or not these patients have an email on file. Doesn't tell you their email, but if you're trying to recruit people with email, a lot of people want to know if we even have an email address. There's ethnicity, a Frontiers Research Participant Registry. I don't know how many of you are familiar with that. This is a registry of people who have agreed to be contacted in the event that they meet clinical trial requirements. So this is a quick way to search to recruit patients or to obtain contact information for patients for trials.
And so the distinction would be, of course, normally when you recruit for a trial, you go through the patient's care provider. It's their physician. So a lot of times, if you're not in a treating relationship, you're struggling at times to figure out how do I approach patients about a trial. So you could still establish relationships with direct physician teams, but this gives you kind of a pool from which you can recruit kind of by going more directly to the patient, though there's a review process run by the CTSA Frontiers, and there's letters that you have to create that go to the patient's physician. But it kind of gives you, oftentimes for many common conditions, you'll find that there's a fair number of people who meet criteria who are in the registry.
We've got gender, language, marital status. As far as location, we've got distance to KUMC. One thing about HERON is all de-identified data in here, so we do not have any zip codes, but we do have distance to KU. One thing also about the age, when we bring the data into HERON, to de-identify it, we shift the dates, so people are shifted up to 365 days into the past, and their entire record is shipped that same amount. So while you may be looking for, you may pull somebody over that's 9 years old, that's give or take a year because it's de-identified data. So, that may be somebody who's actually 10 but has been date shifted into the 9-year-old range. If you need exact dates, you can do an identified data request, but just remember when you're searching here, and it is de-identified data. Faculty members can request it through the front page. There's a data request, and I'll go into that a little bit later as far as how to request the data.
But you essentially have to have IRB approval.
Right.
So the distinction is you can request de-identified data without IRB approval. If you need identified data, you have to have IRB. And this is a point worth getting home. It's just that the distance between all the events are exactly like they are in the real world. It's just they're shifted backwards in time randomly by each patient. So if I was born at this point in time, my new birth date in Heron 1 month might be 5/12 of 1968. And a lab result maybe that I had recorded in 2012 is going to be shifted back the same number of days. So if the offset when they loaded the data was -63, every factor is going to be offset by the same amount. So you can answer a lot of questions with de-identified data. It's safer from a HIPAA perspective, a risk of disclosure. But if you're interested in seasonal activity, you would need the real data or a limited data set. Yes? Everybody is always backset. Everybody's always backset. So I would say there's two ways to look at it, right? If you're looking at it over time, right, once you go back beyond a year, it's pretty much going to be the same number. But if you're looking at this moment in time and you want to count back a year, right, so if you think about it, you can have people sitting in a given year, some of these people are going to be back here, but some of the people in the subsequent year are going to be in this bucket of people, right? You're pretty much searching that year because the people you're losing to the prior year are probably coming in based upon the 14 data if you were looking at 2013. Now, of course, that can vary because we may see more patients, now than we did before. But as a rough rule of thumb, you're pretty good, I would assume. You could, but if you're thinking about it in general, what I would do is if I'm looking at right now, there's a couple key things you want to look at. One is the system will always tell you at the top how fresh the data are. So right now, we're working off of data that was loaded that included all of the data for the month of May. So if I wanted to get a rough rule of thumb count, given this offset, I would just tack on an extra 6 months from the start of that day. So I might look at an 18-month window from, the end of May backwards to kind of get a rough sense of how many people there are going to be in a year. That's kind of my mental model. It should get you in the ballpark.
And also, so we shift dates, but we do that with each release as part of the de-identification. So I may be shifted 10 days this month, but the next release I may be shifted 100 days. So if you see a big difference in numbers between your searches, it could be due to the de-identification process. But usually it averages out.
But you may see slight variability. And again, this is all to protect the privacy of the patients.
Okay, and vital status.
Oh, let me hit up on one more thing. So this is a coming attraction. So Mei Liu in the back is working on a project to geocode. Has anybody ever heard of geocoding? Show of hands. Okay, so what we're doing and we'll talk later about the Greater Plains Collaborative where we're working with 10 other Midwestern institutions. We're going to go ahead and geocode all the addresses we have out of essentially Epic and IDX. And we can't bring into Heron those details, but we're going to get data down to the census block level. So in addition to, right now what we show you in Heron is we can tell you how close they are to KU, because that meets HIPAA standards for de-identification. And that can be useful to you to think about, I want to recruit people who are roughly close by, right? That would be potentially valuable. You may not want to have a trial where you're recruiting people who live over 100 miles away because they may not be able to make it in. But we're going to look over the coming year to bring in geocoding facts about all the patients that we have, which will be pretty powerful because we'll be able to say things like, we won't tell you, well, if you have an identified data request, we can go back and get you their census block. But what we'll be able to bring in are attributes about the census block within that patient lives. So you could know, for example, this patient for sure lives in a rural area, or they live in a census block that has a high Hispanic community, or the average income of this census block within this person lives is this. So if you're targeting kind of diverse populations, that data we hope will be valuable for people's research. So stay tuned. That'll be a coming attraction.
Also of note in demographics and vital status, we have deceased as recorded in O2, and then we also have deceased per the Social Security Administration. So this is another great way to exclude any deceased patients when you're trying to recruit for clinical trials.
And it's kind of like dead according to who. So you got dead according to the hospital and dead according to the Social Security Administration that we integrate.
Okay, diagnoses. We've got diagnoses listed. It's organized by ICD-9 codes. So you'll see the numbers. If you know the ICD-9s, you can quickly narrow down to your desired diagnoses. The flow sheet.
Modifiers, skip that for later.
I'm going to do modifiers after break. We'll talk a little more about the diagnoses after break and modifiers within them. We've got flow sheets, which is all the nursing data, and this is a lot of data. You can see there's 9,270 million, or 927 million facts. One thing I have not highlighted yet, we've got numbers after everything, and this is the stats for how much data we have. So the patients are the number of patients, the facts are the observations. So, for example, up here under diagnosis, there's 828,000 patients that have had diagnoses 78 million times attributed to them. So within the flow sheets information, you're going to be most interested in the data within KU and UKP. There's a lot of data in here. You just need to get in there and start going through it.
Maybe open up a little bit. So has anybody documented or is familiar with nursing flow sheets at all? Okay. So what you'll find is the same in an ICD-9 code tree. Everything you're looking at has got these terminology vocabularies in tree form. And in the world of ICD-9 codes, the code is only going to live in one of those branches of the tree. In flow sheets, nurses will document what are called groupers that live within templates. And so you may have a template or grouper organized for, let's say, OBGYN, newborn delivery, might have a slightly similar template, a little bit different. The burn unit will have a template where you're recording things in the burn unit. So what you're seeing here is if we go down to KU and scroll down to KU IP, that's kind of the KU inpatient templates. Here you're kind of seeing now every template that's in the EMR. And so you can see kind of each of these areas may have their own templates. But when you drill down, so let's go down and look in, if we looked at like maybe peds. Yeah, you could look in here and see what are they documenting here in there. So they will have in that a peds vital sign template. And so then here are a series of things being documented by pediatrics. Now you may get down to a single spot like height, weight, and they're going to have some things that are, the fact of weight is the same fact across the whole enterprise. Does this make sense? So when you see that there have been over 3 million weight facts recorded, that hasn't been just on the pediatric unit. That has been across the entire enterprise. Does that make sense to people? So just be aware, like in other places you look in HERON, the data will kind of be data that was sourced from within that higher folder. But with flowsheet data, it's really showing you the fact that different nursing units organize their templates to point to the same atomic fact. So when she'll show you search capability under find terms, you'll see that at times. So if you search for things like heart rate, it may show up in multiple templates, and that's just, that makes sense. There are some other idiosyncrasies with flowsheet data, and the other comment on flowsheets is right now we're bringing in everything that has a discrete value, but we're not bringing in free text flowsheet data yet. We're working to be able to know that we can fully de-identify the text and then we'll be bringing in all the notes that are might be little snippet notes within flow sheets. And for our people, like one of the early customers of Heron was a gentleman, Saddam Kanan, who was a grad student in physical therapy. And so it's really neat. Are you in the inpatient? There's a lot of data in here that I'll just put a shout out to this hospital because we've started doing work with other people in the Greater Plains Collaborative to look at how they document in Epic. And KU Hospital, to me, has done, when they built out Epic, they did a really rich job of thinking of how they structure discrete data in nursing. So you can look at things like physical therapy is documenting very detailed data about physical therapy assessment that may not be widely done at other institutions. There's data under OT that I've always thought would make a neat project because they're documenting, if you go into adult OT and you look at things like home living situation, we actually have data in this system. So if you were looking at, what's the impact of the home living environment on obesity post-surgery, you would see things like, well, does this person live in an apartment? Do they live in a house? Do they have, open up that stuff, There's a lot of really cool data living in flowsheet data that represents a lot of effort by the O2 team to build it and a huge amount of effort by the nursing and other professional staff to document it. So it's kind of, I think, a unique resource we have here at KU. But on the downside, it's kind of like the Wild West of terminology. It's not as standardized as other data sources.
Okay, history. We've got family history for various diagnoses. You can go down to the parents, grandparents. You can narrow that history down to even maternal aunt, paternal aunt, or just general if it's in the family or not. We've got social history, which you can look up tobacco usage or sexually active. We've got surgical history, if somebody's got had a history of surgery in certain areas. Laboratory tests. You'll see we've got two folders for laboratory tests. One is in draft and one is not. And you'll notice there's a slight difference in the number of patients in each. But so we're bringing in this laboratory test is a hierarchy provided by the O2 system. This is a national standard called LOINC that we're trying to map this to. So you can search in whichever folder you feel more comfortable in, but it's pretty much searching the same data.
But to point out, over time, you'll want to build queries against the LOINC hierarchy. And the reason is we're doing work to make our data essentially then interoperable with the rest of the country. And the path we're on is to allow you to search KU, but then you may want to benchmark what you're finding and look at your colleagues in Omaha, Nebraska, or Wisconsin and say, hey, how many people do you have who've got a low creatinine, clearance? So what you're seeing is in all the trees we live in, there's some data that we get out of the EMRs or the billing system that's already coded to a standard like ICD-9 codes or CPT procedure codes. They're kind of billing centric. But increasingly over the last decade, and has anybody heard of meaningful use before? Right? Okay, that's kind of this billion-dollar incentive to get people to use these darn computers in clinical practice. The goal is you're using something not just to use it, but you're collecting data that's standardized. So when we come along with Heron and harvest the data, we'll notice data in Epic that is non-standardized, but we're looking in Epic to say, can we map this to a national standard so that you could build a query here to look for people with acute kidney injury that are exposed to a nephrotoxic drug, and then you may want to compare that with other people across the country. So using the standard ontologies as we develop them will let you do that type of direct comparison. So that's kind of a continuous voyage we're on here as an informatics team with other people around the country.
A quick side note on the data. I had mentioned that you see after you see the number of facts and the number of patients, you'll notice, especially in this LOINC hierarchy, there's some, they have numbers after them. That's their LOINC number. So if you know the LOINC number, you can search by that LOINC code. But you'll notice, like, for instance, fertility testing. This one does not have any patients after it. That means we don't have any patients that have been mapped to that testing. Don't search on that field because you'll get zero. So when you create your searches, you usually want to create them with concepts that have numbers after them.
That's a good thing. We thought of that early on. We're kind of like, you'd look at all these terminology folders and you get really excited. But until we brought in these things, I mean, we thought, let's show you right away if it's a dry hole. There's no sense dropping your fishing rod in our fishing analogy, when there's no fish in there. So this way it just gives you a visual clue that, somebody may have built this in the flow sheet to document this, but in fact, they never ever do it. Or there may be a place in the diagnoses where one could document this rare disease, but it's never done, or it happens, but it's very infrequent.
Okay, let me go through medications. So this folder, it's a rather large folder. There's lots of medication types. We've got it ordered by type of medication, and then you can drill down into the plastics.
So she's in Antonia. Pick your favorite.
Products.
Okay.
And as you can see, you just keep narrowing down until you get that one that you're really interested in. And then within, it's got the various doses. It's got the number of patients after. You can keep going down. You've got.
I'll go scroll up. So this is one area where what you're seeing here is the high-level folder, thrombolytics, is a class coming from the National Library of Medicine. It's actually called the VA's NDFRT classification system for how they classify medications into categories. And then again, this is a place where we're mapping it to a national standard called RX norm. So we take the data out of EPIC and we park it under RX norm. So this Alteplase injectable solution, at KU, they dispense that in both Activase, which is the brand name, and they've also dispensed it in the generic name. And so what we've attempted to do here for you is, as much as possible, if the EMR or some of the natural language processing, and this is all Nathan Graham's work, so you can thank Nathan, or you can tell Nathan where there are opportunities for improvement, which is what May's been doing. We're trying as much as possible to park all those things under that semantic drug form so that you don't have to build a query with every single dispensable size. But there are times where we'll find a file like that top one where it didn't map automatically into the injectable solution folder, so we'll tend to put it in the same subfolder. Is that a good description, Nathan? So again, use it. Be aware that that's we're trying to get most of the things to fit there, but go up to the other concepts folder. But there is a list of things that Nathan, go down a little bit, was unable to map, okay? And this is and it's, it's 10 million things out of 140 or how many millions. So there are things where we need to figure out how to do a better job how to map piggyback files. A lot of these are infusable piggybacks that weren't mapped in the EMR to their parent class. And then other things are things you'll see in here. Some are herbals or things where it's hard for us to tell what artificial saliva is. We don't know where that lives. So if you're building stuff and you want to be complete, build it off of the folders. And those can be very useful because you may be thinking about a drug class and you remember off the top of your head 5 of the 7 items, but you forgot what the other 2 items were. So the folders help you there, but then also browse the other medication concept folder to see if you're missing some things that we haven't mapped. And I just noticed that a lot of these wind up being piggyback files. And then they also wind up being some things that are either generics or not generics, but there's just a mixture of things like Clean Mix Parenteral Nutrition. There's a lot of nutritional supplements, or cranberry concentrate PO is something that obviously didn't map well to a drug class.
The next folder, we've got microbiology information, and we've also got the negative and positive results, so you can search. So you can search if you're interested in positive or negative, or you can search in microbiology.
So open up the main draft one. So the main idea here is, if you open up the blood culture, you'll see this folder, because the data is kind of organized differently. This folder is showing you do a blood culture, it was positive. What types of organisms did they discover in that culture? And then, as she'll talk about modifiers later, but you can also kind of get a sense of, was it tested as susceptible or resistant to certain types of antibiotics? Yes?
Say that
Um,
In this case, what you're seeing here is like, look at this top guy. He's got 85 facts or three. What this, so when they get a positive culture back on a patient, we generate many, many, many facts because we're generating a fact about all the antibiotics they tested and the susceptibilities. But if the total number of patients is less than 10, we don't show you how many patients they are in heron because we are worried about the potential that you're trying to maliciously re-identify a patient. So when you see things that only have a fact listed, it's because the total number may be very small, or you're in that flow sheet folder where we have so many facts, it takes us a long time to calculate the statistics. But very good question. Yes? That's correct. And you'll see that all over Heron, right? You'll see when you're looking at any folder, you'll notice that there's oftentimes way more facts than there are patients. That's because a fact is, in the case of lab tests, they've had serial BMPs drawn time after time. Here, you're seeing a lot of facts for two reasons. One is because they may have been tested twice or three times, but the other reason is for a single blood culture, we're generating facts about every type of antibiotic tested on that organism and susceptibility results on that. So it can generate, it's kind of an order of magnitude more facts about a blood culture than there are about a basic chemistry test. And I'll comment, and Shravani is the expert of microbiology. The other component then we got into as we worked with other people at KU like Rebecca Horvat was, well, we want to know how often it's negative because, really from a cost effectiveness standpoint, you order tons and tons of these tests and you want to know, was it negative? So we bring in the fact that that test was also negative. And then the third component is there are other types of results for microbiology like C. diff that are not they don't follow a testing pattern where they're testing them for susceptibility. It will just be this is positive for C. diff. So that type of data lives under this positive results tree. If you're interested in this area, browse, and then I think Shravani can put you in touch with other people kind of using the data like, Wissam Elatruni has been the main infectious disease faculty member working with us on that
okay,
area.
the next folder is labeled procedure orders. This is more orders. It's not specific to just procedures. So you can find any time an order was submitted. It can be consultation. It can be radiology. It can be surgical procedures.
Go ahead and open that up. I want to give you a little bit of shout out. Okay, so I used to do CPE at Vanderbilt. Orders are really cool to me because that's what the physician actually wanted to have happen. And a lot of orders will not generate a bill or generate a result necessarily. So there is a lot of good data in here that you could look at. If you were looking at process things like how often is the order getting kicked off and how long does it take for a result to roll back in, it could be valuable data for you, as well as, there's a broad breadth of types of things that may be living in the orders area. But it is different than a result. So you may see the test was ordered for the echo at an orderable level, and then you would look in the cardiovascular lab results to see when the echo's results came back. Similarly for labs, and then in the other point, close the folder out. The other bucket is procedures, and this would be the billing side of the house. This is now that they've done the test and they're billing for it, this organizes both inpatient procedure billing codes and CPT codes for professional billing. Yes? The start date, that is a great question. You'll see here, go ahead and describe.
Okay. So every time there's a release, you get to, when you log into Heron, there's a little acknowledgement you have to sign, and it'll show you the date ranges. So currently, we're through May 2015, and so as far as procedure result, you can see we've got the start date and end date, and it tells you the source of the data. And this is actually a good resource. And that handout I have for you over there, it has just an example and the URL to go to get this information. But you'll see some stuff comes from the billing, some stuff comes from O2. As far as the procedures themselves, looks like it goes back to 2000 because the majority of them are coming from the IDX system. It goes through May 2015. So it's important to reference this because if you're creating a search and you're pulling data from two different systems. You know, O2 went live in 2007. So if you're trying to search back to 2000, you strictly need to be using the billing, or cancer tumor registry goes back to the 50s as well. You strictly need to be using those types of data, or you need to understand that you're not going to have, you know, any diagnosis in O2 prior to 2007.
So this is kind of a reference sheet. You know, November 2007 is when Epic was turned on in the inpatient side of the house. I think pilot testing in 2011, they started rolling it out in the clinics. So depending on what you're looking at, you may or may not have EMR data available. The billing system used by the University of Kansas physicians groups, most of the departmental-based things, we've harvested that data back to 2000. We actually have some work on our team we got a timeline to start now that the hospital has switched over to Epic for billing. We're going to start bringing in the Epic billing data to kind of compare with the EMR data. But very good question.
And just for reference up here, there's a link to HERON Help, and it's a help page, and on that page there's a link to that blog that has that information as well. So you can access it anytime from within here. Go. So those are the procedures. One thing to note, in the procedures, you know, we've got a lot of radiology procedures in here. We don't have any results. All we have is that the procedure occurred. We do not have any images in here or any free text. So you would need to reference the medical record for that information.
Although that leads to the next topic.
Reports. Go ahead and discuss.
Yeah, so leading to that, we've got two types of things here. So if you want to know at least that a note was written, we have the note types out of Epic loaded. So this would let you know that somebody did write a progress note. Again, some of this is related to de-identifying the data. So right now in HERON, what we have is we have the types of notes written, and then is anybody familiar with the note writer in Epic as physician notes? So, you know, there's kind of like you can have Epic receive a free text document that somebody dictated, and then you kind of have these Madlib templates you can use. But the Madlib templates, when they collect the actual data, the final document is saved just as a text report. But if you use the note writer, where you can kind of pick structured concepts, we've harvested all that data. So what we plan to do over the next year is we actually want to bring in all the raw free text notes so that people could search it with IRB approval. And if we can work with our partners to do de-identification, we will try to bring in de-identified notes that you could actually search in HERON. There's a feature built into the IGB2 software that would let you search text notes. So you could look at dictated reports and say, oh, look, I want to look for a certain phrase. So coming attraction, bug us, you know, if we don't get there. But our goal is to get there. But right now, you can at least know here are all the types of notes that have been written. So if Dr. Kovac was interested in, you know, in this patient population, you know, when was the post-op note written, or is that available? That could be useful to you. You know, you could be looking at a burn population and want to know roughly how many notes am I going to have on this group. So that can be a way for you to filter. But when the note writer has been used, this data, again, this is an area where we brought it in and we're not sure that people have really, you know, our fishing analogy is you're kind of fishing this big lake of data. Sometimes people want to look for certain types of fish, sometimes they don't. So sometimes we bring in a lot of data that sits there. But I think if you look at this, you will find, especially for the physical exam components of note writer, there is a lot of valuable data in here. So you can kind of see when this note writer tool is being used and people are evaluating the patient for cardiovascular edema, there are facts where it's being recorded, very well structured, that yes, this patient has left lower leg edema, and it was recorded as yes. So if you're a person working in that world where we're entering a lot of data in note writer for our patients, and you want to explore what's coming out, check out this section where it's organized all these Epic concepts, because that may be a potentially useful data source for you. Same thing goes for heart sounds. You know, this would be people doing their interpretation of heart sounds on that exam, and you're seeing here there's a fair amount of data on, you know, what they were finding there. So.
The specimen folder. This has biospecimen repository here at KUMC. It's got their data. So if you're interested in somebody that has tissue on file or fluid, that's what this folder is. The University Health System Consortium. This is a great folder if you're doing any inpatient research. This is strictly inpatient data. It's got visit details as far as a length of stay. If you're interested in searching for people who have had a hospital stay or ICU, days within the ICU. There's days to readmit, so you can do some searching on readmission rates. Physician specialty and roles. It's got a lot of, I don't know how many of you are familiar with the University Health System Consortium, but this is taking the data. Our university here submits this data to the University Health System, so we're ranked against other institutions. We get a copy of that data, and we pull it in here. So it's a lot of the same data you'll find in diagnoses and procedures, but it's formatted in a structured way.
Has anybody ever used UHC data before? Okay. So what's neat? So what happens in the hospital is they generate bills, and then the University Health System Consortium provides benchmarking between academic medical centers. So once we learned about this, we thought this is really valuable because at the time, the hospital's billing system was this old SMS system that was going to be retired. So we said, let's pick off this data off of the UHC data feed because it's helping build out these trees in HERON for the ICD-9 codes and the diagnosis codes. And she'll talk about the modifiers later. But once we started harvesting it, we realized it has all types of other beautiful data as well. So if you were studying things like how many people are having this problem and it was because they're emergency versus elective cases, or a really great area for transitions in care is this would be the hospital's definition of after they left the facility, where did they go? So if you wanted to explore like rehabilitation and who's going to a rehab facility, this data could be very useful for you. If you were looking, there's also information about primary payer, what types of physician specialties were involved. There's data in here about the diagnosis trees in here are not ICD-9 codes, but if you've ever heard of diagnostic-related groups, which are kind of a high-level way to roll up the case, the DRG codes are here, as are things like risk of mortality and severity of illness. And then another way you could triangulate on data would be AHRQ and Joint Commission have defined kind of standards for saying that someone falls into a certain class. So you could potentially use this as a definition for studying a congestive heart failure population. Does that make sense to people at all? Have I lost anybody there? Yes.
They're more refined type of DRG in terms of severity of illness with mortality. And I see that they're based MS DRGs too. And so what you have are two different types of sets of numbers. So I wouldn't want anybody to say, oh, I know the DRG for something and go into APR DRG when it's actually not the MS.
Yeah, you have a choice here of which type of DRG do you want to use. You've got 3 types that you could use. So when you look at it, this is one thing I would just say in general about research. If all you had was one data source, right? So think about it. A lot of health services research has been done on billing data, and everybody complains about the billing data, that it's not reflective of clinical care, but the benefit is that's all I got to look at, right? So if all you had to look at were CPT codes from ambulatory service care and you had diagnosis codes, you kind of have what it is, and you'll complain about people like Judy that they falsely code the diagnosis, right? When you have something like HERON where we're bringing in all these data sources, it's almost like, I think I heard somebody talk about the tyranny of choice when you go shopping. You have too many choices to shop about, but it does give you flexibility to say, I want to look at this problem and say, how did the physician code it? You know, what were they assigning as diagnosis codes in the EMR? But you have this ability to say, and as Judy's pointing out, even in the billing environment, depending on who the payer is, they will classify data differently. And as I was showing you up here, when you look at things like the University Health System Consortium or Joint Commission, there are other categories of ways that the data can be organized, and those are available to you. There is a little bit of a tyranny of choice of, find maybe people experienced in health services research who can help you in certain cases, or just be aware that if you define a diagnosis from one perspective, there may be slight disagreement when you look at it from another perspective. Does that resonate with people at all? Okay.
And then the last folder is visit details. And this is a great place to get information for your visit vitals if you're interested in BMI or height or weight, blood pressure. It's also got a place of service from the billing system, and it's got an encounter type. So if you're interested in inpatient, outpatient, there's an emergency department episode here. You can pull that in there, and it immediately narrows your search down to those that were seen in the emergency room. We've got clinical services for both in and outpatient, and then there's also age at visit. And this is different from the age and demographic. So when you're saying, I want to search on people over the age of 65, okay, do you want, or let me change that. I want to search on pediatric patients that were 12-year-old when they had the HPV vaccine. Do you want 12-year-old right now? Do you want 12-year-old age at visit? So for that example, you would want them to be 12 at the age of visit. You would pull this in. If you're doing a search where you just want patients who are 12 right now who have been seen in the past year, then you would use the demographic age. Does that make sense? Did I lose anybody in that one?
Another common question asked is the vitals in here, how do they differ from the flow sheet vitals? And the answer is the flow sheets, I think at least per encounter, drop into this folder as well. So it's not like if you just want the vitals, you can often use this. Yes, but what you'll notice here is these visit vitals, there's a smaller list of kind of globally mapped visit vitals in EPIC than there are on the flow sheets. Because on the flow sheets, you could have intracranial pressure being measured in an ICU unit. That doesn't show up as kind of a generic visit vital. So, but for a lot of the basic things people want, this visit vitals is a very good source. And then a lot of work that Vince has done with population health has led us to kind of iteratively improve, bringing in a lot of this data about where was the place of service. So this is coming out of the clinic billing systems of where exactly was a place of service, which can be different than what clinic did they visit or what clinic billed for the care. And you'll see here are inpatient visits. These are kind of all the inpatient areas. So inpatient is a relative phrase because some of these may be procedural areas as well. And then the outpatient visits is largely looking at the UKP billing data. So I think, Vince, we're working to bring in the EPIC data as well. So we'll continue to get better there, but those are good ways to filter your data.
Yes. David, from the Spine Center?
So I guess the question would be, the Spine Center is a UKP-run clinic from a billing perspective? It's a hospital clinic. Well, let's look. Does it show up under inpatient services? Spine, potentially? Yeah. This is kind of misleading. These are the kind of unit locations in, quote, EPIC. So we kind of labeled them inpatient because they mainly came out of that, but it could very well be that this is a way of capturing that the patient did go to spine. And then from that, if you wanted to look at something like, did they have a certain, at least have they had a report generated, you could conjoin that with, note type data. Well, we can take a look. So my guess is with 27,000 people here, this is probably accounting for a lot of your ambulatory people, would be just my sense. We can probably go into a little greater detail, have somebody work with you to search, but I'm assuming you may find that using that characteristic combined with some other data may get you, any observations you would have, Vince, on that? Details. Yeah. and then looking at, it's kind of probably mislabeled inpatient services because we mainly approached it first from the Epic. At the time when we loaded this, Epic wasn't used yet in the ambulatory setting, but it is, I believe, rolling in a lot of data from visiting these procedural areas. So that's where I grabbed spine. So if you then within this population wanted to look at something else, um, like if you were saying you wanted to do the flip and you wanted to look at people who you knew had who had a certain, you could bring in another fact to narrow your population.
Yeah, you could bring length of stay over and exclude it to see how many of them were strictly outpatient.
Yes.
Well, then, like in the spine center, like an anesthesia or chronic pain physicians are there to do a lot of procedures. How would they look for that? There's a lot of them are on ambulatory basis.
So you're looking for, you want to look.
So like to follow up on, because we have the spine center.
Mm-hmm.
Okay, then we have chronic pain physicians, and they're doing ambulatory procedures. Would that be in the spine center? Would that be an ambulatory?
Is that the pain management?
Yeah, so these chronic pain.
Yeah, so I wonder if it's pain management, is there pain management in that?
How do you want to denote that they were practicing in that area? So for example, here we would say the majority of these patients, if I exclude the people, well, and this actually probably what I would want to do is I would actually want to run this. This links up now on the same financial encounter.
It does.
I'm going to wind up, if I go too deep into it right now, we're going to get really deep into the system. But what you'd wind up doing is saying, I want to look at people who have been in the spine center, who have maybe not had hospital length of stay recorded during that same financial encounter. And then I might bring in other characteristics like, did you bill for chronic pain? Or what other attributes about the chronic pain team do we want to see? And we could look, for example, you could look in here and say, the chronic pain service is a component of anesthesiology. Is that in IDX? Do you tag it as having a specific category? So like here, anesthesiology, is it mainly going to be recorded as the main anesthesiology team? It doesn't have a subunit. It's that, you know what I mean? But yeah, you would say, okay, I want to know how many of them were seen by KU at that visit to the spine center during the same financial encounter. That would start getting you there. And then if you had a couple CPT codes where you say, I know I always bill for this, you could drag that in as another fact. And then you could potentially further refine it by saying there may be other things you're documenting in the record as you browse your data that would let you know this is, well, here, like if you had a specific type of anesthesia note that was labeled as the chronic pain note, you could clearly bring that in to define the population. But really good questions.